Hi, I'm Dr. Jennifer Howe, and I'm here to talk to you all today about guidelines for the care of infants with perinatal HIV exposure. We'll talk about two broad topics today. The first objective is to go over guidelines for infants with perinatal HIV exposure, reviewing their risks of acquiring HIV and how to assess that, as well as antiretroviral drug management. The other large topic we'll talk about is breast milk or breastfeeding associated transmission of HIV, how to assess that, and how to counsel patients on infant feeding, as well as how to manage. The first thing you want to do when you have an infant whose mother has HIV is to assess the risk for HIV transmission in that infant. So high-risk infants are those who are born to people with HIV that meet at least one of the following criteria. One, the mother may not have received any prenatal care. Two, she could not have received anything except for intrapartum antiretroviral therapy, or she didn't receive any antepartum antiretroviral therapy. She may have been diagnosed with acute or primary HIV infection in pregnancy. She could have been diagnosed with HIV during labor or postpartum, or have an unknown HIV status. Or lastly, she may have received antepartum antiretroviral drugs, but did not achieve sustained viral suppression defined as an HIV RNA level less than 50 copies per mil by 4 weeks prior to delivery. Every other situation would be considered low risk. The French perinatal cohort gives us some information on why the timing of initiation of maternal ART is so important in assessing risks for HIV transmission in the infant. You'll see here in this large study that the odds of acquiring HIV for the infant were higher by 7-fold, 6-fold, and 2.9-fold. Whether the ART was initiated in the third, second, or first trimester compared to before conception. So really, late ART initiation puts the infant at greater risk for acquiring HIV. Why also do we want to assess the high risk versus low risk? Well, there are certain rationale that we adhere to for empiric treatment. Especially when you're worried about in utero HIV acquisition. Those infants are considered to be at highest risk. And if we look back to the Mississippi baby, we'll find that that particular infant had in utero HIV infection, but ART was started very early, within 30 hours of age, thereby limiting the seeding of viral reservoirs and limiting the seeding of viral sanctuary sites. So what we try to do is really get strong 3-drug empiric therapy on board for the baby early, very early in life, in order to create smaller reservoirs and smaller seeding so that you might be able to achieve remission after an initial period of ART. This is an old study, but it was done in rhesus macaques, and they looked at the initiation of suppressive ART. That's where you see the red arrows here at different time points. And you can see that if treatment was initiated on day 3, that actually blocked the emergence of viral RNA and proviral DNA in the peripheral blood. So again, reduced levels of proviral DNA in the lymph nodes and the GI mucosa were seen with initiation of ART at later time points. So what do we do once we decide whether they're high or low risk? In a newborn with low risk for perinatal HIV transmission, after you've decided they're going to be low risk, would probably receive ZDV or zidovudine for either 2 weeks or 4 weeks. This is a little bit newer in the guidelines because even 5 years ago, 4 weeks of ZDV was the recommended duration. But with the new British guidelines and the current DHHS or US perinatal guidelines, there is an option for zidovudine to be administered for a total of only 2 weeks if the newborn is term, or at least 37 weeks gestation, and born to a person with HIV who meets all of these following criteria here. The woman has to be currently receiving and received at least 10 consecutive weeks of ART during pregnancy. And the mother has to have achieved and maintained viral suppression, defined again as at least 2 consecutive tests with HIV RNA less than 50 copies per mil, obtained at least 4 weeks apart for the remainder of pregnancy. She also has to have a viral load less than 50 copies per mil at or after 36 weeks. And she cannot have had an acute HIV infection during pregnancy, and there should be no concerns for ART non-adherence. If and only if all of those criteria are met, can you sort of deem a child to be at low risk and possibly receive only 2 weeks of zidovudine. If a child's not low risk, then they're high risk. And you have 2 options for recommended ARV regimens for high-risk infants. One is to give presumptive ART therapy with zidovudine, 3-TC, and nevirapine. And the other is to give an alternate regimen of zidovudine, 3-TC, and raltegravir. What you would do is, if the birth PCR is negative, you would administer the 3 drugs for 2 weeks and then continue ZDV alone through 6 weeks of age if that birth PCR is negative, after discontinuing the 3-TC and nevirapine at 2 weeks. The same applies if they're on a ZDV 3-TC RAL regimen, just swapping out the duration of RAL and nevirapine. And of course, if the birth PCR is positive, you'd continue ZDV 3-TC, nevirapine, or RAL and consult a pediatric HIV specialist. These next couple of slides are just so that you have an idea of the kind of weight band dosing regimens that we have for the 3 drugs I just mentioned. Here is ZDV, or zidovudine, and there's weight band dosing for low-risk prophylaxis as well as high-risk prophylaxis, including empiric HIV therapy. For ZDV, we have plenty of dosing guidelines down to even less than 30 weeks gestational age at birth. For 3-TC, you would not be using this for low-risk prophylaxis, but in a high-risk prophylaxis situation, we do have dosing down to 32 weeks gestational age. If the child or infant is less than 32 weeks, we advise you to consult the Illinois Perinatal HIV hotline. Here's the nevirapine dosing guidelines. Again, nevirapine would not be needed in the immediate postnatal period for low-risk prophylaxis, but in high-risk prophylaxis situations, we do have nevirapine dosing down to 32 weeks. If the infant is less than 32 weeks gestational age, we'd advise you to consult the Illinois Perinatal hotline. And last but not least, raltegravir here. We're showing you some weight band dosing regimens. Raltegravir, it'll be important to note, can only be given in term infants. So the infant must be born at least 37 weeks gestational age at birth and weighing at least 2 kilograms. Some challenges we've noticed with giving raltegravir in newborns. There's a large 20-page instruction booklet on how to actually prepare the doses, and it's not as easy as giving a syrup that's pre-mixed and given by the pharmacy. It's difficult to get these granules into suspension, and then you must dose that drug within 30 minutes of mixing it. The dosage also changes again at 1 week of age, so this usually necessitates an extra clinic visit. And it's important to tell the mothers or parents that even though we dispense several packets at a time, after the dose has been measured out, the rest of the packet needs to be discarded. This oftentimes results in a very wasteful situation. So And it's also difficult for parents to understand that this needs to be done. So we like to reserve raltegravir use for infants born to ART experienced mothers who may have nevirapine-resistant virus. So that's all about what to give in terms of ARVs for high and low risk infants. What about how to monitor them? So for the low risk infant, you would perform an HIV DNA PCR or RNA PCR or total nucleic acid test at 2 to 3 weeks, 4 to 8 weeks, or 4 to 6 months of age. These are the time points. And you'll notice for high-risk infants, there is a slightly different schedule for this NAT testing, in that high-risk infants will also have a birth NAT testing done, and then they will also have an 8-week NAT testing done, which is usually 2 weeks after completing their antiretrovirals. The other time points are the same as a low risk, 2 weeks, 4 weeks, and 4 to 6 months of age. Going back up to the low risk infant, we like to just emphasize that any infant with a positive PCR or NAT testing should be immediately referred to a pediatric HIV specialist. Additionally, for high-risk infants, we recommend obtaining a CVC with a differential at 4 weeks of age if the infant is still on 3 antiretrovirals. This is because zidovudine and 3-TC together, or zidovudine alone, has the potential to cause bone marrow toxicity. We also recommend obtaining a urine or saliva for CMV PCR before 3 weeks of age in high-risk infants. Also note that, again, any infant with a positive PCR, especially in the high risk, should be immediately referred to a pediatric HIV specialist. Lastly, I'd like to note that if the mother had acquired her HIV outside of the US or Europe, she may be infected with a non-clade B viral subtype. And so in this instance, we would recommend that an HIV RNA PCR be performed in the infants in order to pick this up. How about pneumocystis jirovecii pneumonia prophylaxis? Well, we only recommend PCP prophylaxis beginning at 6 weeks of age for infants with a positive DNA PCR or NAT testing. When that happens, again, consult with a pediatric HIV specialist. Just a note that PCP prophylaxis is not recommended if the DNA PCR or NAT testing performed at 2 weeks and 6 weeks of age are actually negative, unless, again, you have a positive prior PCR. Okay, let's tackle breast milk associated HIV transmission. What do you need to know? Currently, the guidelines, both federal DHHS, US perinatal guidelines, as well as the Illinois perinatal guidelines, have been rapidly evolving with changing recommendations for breastfeeding in women living with HIV. We like to recommend here that all mothers with HIV receive counseling about infant feeding, and that, a hardline prohibition of breastfeeding is really not the best way to do things. It might actually inhibit mothers from expressing her actual wishes and plans. It's also a lost opportunity to educate, and sometimes we note that the mother may still breastfeed intermittently, but just not let us know. We also try to provide non-judgmental, open-ended questions about their feeding preferences, all done in sort of the antenatal arena, not waiting until the baby's already born. Do your best to understand the context of the woman's motivation. Maybe there are issues about health benefits from breast milk that the mother really wants to capitalize on. There could be cultural norms in resource-limited settings, and there may be a fear of disclosure of their own HIV status if they formula feed. There could be plans for the mother to return to their home country in the near future. Try your best to validate her desires and really educate regarding the risks versus benefits and allow them to make an informed decision. This slide really gives you an idea of what kinds of rates of breastfeeding transmission are out there. It's an older publication, but this is a smattering of some of the major studies in Africa, which have looked at breastfeeding transmission. And overall, the transmission risk is about 1.1%. Bear in mind, most of these studies were done at a time where universal ART for the mom, both antenatally and postnatally, was not always the standard of care. So we desperately sort of need new trials now where we can evaluate breast milk associated transmission in the face of 3-drug maternal full ART during the postnatal period. And we do have that with PROMISE, which is one of the newest studies in IMPACT that evaluated this. So out of 1,220 mothers on ART, they were able to evaluate cases of both perinatal transmission, in utero transmission, as well as postnatal breast milk associated transmission. And what I want to bring you in close here is the red circle. And the red circle shows you that there were 2 actual cases where the mom had undetectable viral loads during breastfeeding, but still transmitted HIV through the breast milk to the infant. So although breast milk transmission is low, somewhere between 0.5 to 1.1%, and can be even lower when the mother has an undetectable viral load and is on suppressive 3-drug ART, it is not 0 when the mother is on suppressive ART and has virologic suppression. And these 2 cases in PROMISE demonstrate that. So this usually is a piece of information that a lot of women who are considering infant feeding choices would like to know. Another piece of information we like to tell mothers about is, well, how is HIV found in the breast milk? So one type of HIV is called cell-free HIV, and that HIV circulates and replicates in a cell-free fraction of the breast milk. You can actually measure this HIV when you do your HIV viral loads in the blood. And for that, we know that maternal 3-drug ART really suppresses breast milk viral load. However, there's also cell-associated HIV that floats around. This is HIV DNA that is inside resting T cells, or the latent reservoir. And we know that cell-associated HIV is actually 10 times more efficient at activating from infected cells in milk versus plasma. So we really worry about this cell-associated HIV because ART in the woman does not suppress cell-associated HIV in breast milk. And it's this cell-associated HIV that may play a very important role in breast milk transmission. What else do we like to talk about with our women who are considering infant feeding options? Well, if they're going to breastfeed, we talk a lot about subclinical mastitis and how this can be associated with elevated breast milk HIV viral loads. You can see here in this diagram to the right that amongst women who had subclinical mastitis, the breast milk viral load was much higher than among women who did not have subclinical mastitis. So we know that maternal viremia is associated with transmission. High plasma HIV RNA or viral loads in the blood are associated with a higher transmission risk. But even when ART renders plasma HIV viral loads undetectable, you could still get episodic detection of HIV RNA. And even when a mother is on suppressive ART, PROMISE that study still demonstrated some women to have transmitted HIV through the breast milk. In addition, we like to talk about exclusive breastfeeding versus mixed feeding for women who are contemplating breastfeeding. Exclusive breastfeeding, of course, is when you give no other foods or fluids other than breast milk. Mixed feeding is when you give both breast milk and other fluids or food. And we have noted in several studies that mixed feeding actually doubles the risk of HIV transmission over exclusive breastfeeding. This is because disruptions in continuous breastfeeding actually raise the HIV viral load in breast milk. In addition, the different types, breast versus formula feed, that go into the infant's gut may have a greater chance of irritating the gut mucosa in the infant, making HIV transmission across the gut barrier higher. So what do we do if a woman decides she may want to breastfeed? Well, hopefully these are only low-risk infants, in which case zidovudine would first be administered in the first 4 to 6 weeks of initial postnatal prophylaxis. But the WHO also has extended postnatal prophylaxis for breastfeeding infants, where they use nevirapine in these types of dosing. So our practice is potentially to give nevirapine, extended nevirapine prophylaxis after zidovudine through 6 weeks after the last breastfeeding contact. There is no firm consensus in any of the guidelines currently on what is the best postnatal prophylaxis. Some would recommend no ARVs beyond the zidovudine. Some recommend nevirapine, some recommend 3TC, some recommend 3-drug therapy. But the WHO guidelines here for nevirapine do give us some recommendations on how to dose this. Likely there will be new recommendations and changes in the federal guidelines for the US perinatal guidelines, as well as the Illinois perinatal guidelines coming forth in the next year. But until that happens, these are some useful resources that you have. The top left there is AIDS info, and that is where the DHHS recommendations for the use of antiretroviral drugs in pregnant women to reduce perinatal HIV transmission in the US can be found. To the bottom right there are the Illinois perinatal HIV hotline website and phone number. And these are handy resources for you as you're taking care of your patients' moms and babies to prevent perinatal HIV transmission. Thank you, everyone.